Thank you for tuning in and welcome to the video presentation series titled Limb Ischemia. The work is catered to the MRCS candidates who might find this helpful in revising their exams. There is no conflict of interest and all videos were made for educational purposes only. As a surgical trainee, we will inevitably come across various presentations of an acutely painful limb or limb ischemia that needs to be dealt with urgently. Hence today, we will be discussing an acutely painful limb, acute versus chronic limb ischemia, and last but not least, critical limb ischemia. If a limb is acutely painful, cold and pale, it should be treated as a surgical emergency of acute limb ischemia until proven otherwise. On the other hand, a hot and swollen painful limb should make you think of a probable DVT, especially with calf firmness and tenderness. A neurologically acute painful limb associated with numbness, weakness, and relevant past medical history, such as multiple sclerosis, disc herniation, diabetes, and effective causes should be sought. Lastly, if an acutely painful limb is due to trauma, neurovascular status should be established at an earliest opportunity on top of mobility. We should always have a low threshold for diagnostic imaging if an acutely painful limb is due to trauma. To recap, recognition of acutely painful limb presentations and red flags are important in guiding the timing and the types of suitable intervention. If an acute limb ischemia is suspected, it is wise to involve the vascular team at an earliest opportunities for a reason that we will discuss later. Appropriate analgesia is important to ensure patient comfort who presented with an acutely painful limb. An acute limb ischemia is defined as a rapid decrease of blood flow to the lower limb secondary to an acute occlusion of the artery or a bypass graft. Every limb ischemia is time and life critical, and any presentation that started from a few hours to less than 14 days is regarded as an acute limb ischemia. The incidence of an acute limb ischemia is 1 in 1.5 per 10,000 individuals annually. The causative factors are due to thrombus in situ, such as a popliteal aneurysm causing localized thrombosis, emboli, or trauma that occludes or causing the damage to the arterial wall. The commonly heard about 6 P's of an acute limb ischemia are pain, paralysis, pulselessness, perishingly cold, pallor, and lastly paresthesia. Broadly speaking, the limb ischemia is reversible if the presentation is within 0 to 6 hours and the appearance is pale and without mottling, which will begin to appear between 6 to 12 hours due to capillary pooling. The acute limb ischemia is partially reversible in this case if the mottling is blanchable upon pressure. The limb is deemed not viable if the mottling is fixed, along with clinical features suggesting compartmental syndrome. This is a Rutherford classification of an acute limb ischemia, which uses sensory and motor impairment with Doppler findings as a gauge of classification which will guide us with the management plan. I personally can never stress enough that a detailed history taking combined with physical examinations are pertinent in establishing the diagnosis of an acute versus chronic limb ischemia. ECG is important to look for cardiac arrhythmia, which might be the source and the cause of the emboli. Admission bloods with lactate as a marker of anaerobic respiration due to ischemia. A group and safe sample can be helpful if surgical procedures are indicated. Lastly, a Doppler ultrasound and a CT angiogram can help decide the severity and site of the acute limb ischemia, which will then help with further surgical planning. This is a CT angiogram showing the occlusion at the right popliteal trifurcation. According to the Rutherford classification, stage 1 is classified as a non-threatened limb. Hence, it may not require any intervention. Rutherford classification 2A is a threatened limb without loss of motor function and is salvageable with prompt treatment. 2B is also a threatened limb with loss of motor function, salvageable with immediate treatment. And finally, Rutherford classification of 3 is an irreversible ischemia which is non-salvageable and may require amputation. The treatment modalities of an acute limb ischemia ranges from therapeutic anticoagulation with heparin as the first line, and then it proceeds to catheter-directed thrombolysis, or known as CDT. CDT restores the perfusion through the administration of tissue plasminogen activator, or TPA, via a catheter directly within the thrombus burden. Two of the drawbacks of CDT are the time taken to reperfuse and the risk of bleeding. Many patients with acute limb ischemia do not have the luxury of waiting of more than 24 hours for revascularization, or they are very high risk for bleeding complications. These patients in particular may benefit from percutaneous mechanical or pharmacomechanical thrombectomy. Moving on, mechanical aspiration is one of the simplest forms of mechanical thrombectomy. These can be easily performed without any special equipment. Amputation should and will always be the last resort if the above interventions deemed not viable in limb salvaging. This is a before and after arteriogram demonstrating an embolus occluding the superficial femoral artery and popliteal artery, followed by a completion arteriogram after mechanical thrombectomy and stenting of the superficial femoral and popliteal arteries. Okay, let's now then take a look at chronic limb ischemia, which is essentially a peripheral arterial disease that results in symptomatic reduced blood supply to the limb, which is ongoing for more than 14 days and essentially a clinical diagnosis. Ankle brachial pressure index is used as a marker of severity in the case of chronic limb ischemia, which brings us to the discussion of critical limb ischemia. Critical limb ischemia is also a clinical diagnosis for an advanced form of chronic limb ischemia with an ankle brachial pressure index of less than 0.5. It is defined as more than 2 weeks of rest pain, ulcer, and tissue loss attributed to arterial occlusive disease associated with great loss of both limb and life. 5 to 10% of individuals with chronic limb ischemia will go on and develop critical limb ischemia. The approximate 10 to 15% of those with chronic limb ischemia will die of cardiovascular causes within the 5 years period, and a further 20% of them will have a non-fatal cardiovascular event. Of those who continue to develop critical limb ischemia, there is a high mortality with approximately 25% of them dying within a year, and about 1/3 of them will require a major lower limb amputation within a year. Again, the risk factors are similar to those in chronic limb ischemia in a patient who has critical limb ischemia, such as modifiable risk factors like smoking, obesity, hypertension, atherosclerosis, diet, and lack of exercise. Non-modifiable risk factors include congenital metabolic disease, family history, age, gender, and rarely due to vasculitis. The severity staging is based on clinical features from asymptomatic to gangrene or necrosis pain. Investigations include detailed history taking, the cardiovascular risk assessment, Berger's test, ankle brachial pressure index with Doppler ultrasound, bloods, and imaging like CT angiogram or a magnetic resonance angiogram. This is a table summary of ankle brachial pressure index readings and their associations. The management of chronic limb ischemia is divided into medical and surgical. Medical management of chronic limb ischemia ranging from lifestyle advice, supervised exercise program, optimization of diabetes control, lifelong statins and antiplatelets for cardiovascular risk control. It is because a poor cardiovascular health correlates to poor prognosis in chronic limb ischemia. The principles of surgical management in chronic limb ischemia includes angioplasty with or without stent insertion, bypass graft. There is a role of individualized hybrid therapy, which is a combination of both angioplasty and bypass graft. And lastly, when all else fails, amputation again will still be the last resort. Some of the complications of chronic limb ischemia are like sepsis secondary to the infected gangrene, acute or chronic limb ischemia due to the dislodged emboli, amputation and further amputation causing reduced mobility. And most importantly to note, a chronic limb ischemia has a 5-year mortality rate of 50%. That's the end of today's video presentation. Thank you very much for your attention. Until next time.